Good morning and welcome to the Optimising Health Literacy to Improve Outcomes session during the NHS Wales Value and Health Week. I'm Andrew Carson-Stevens, a general practitioner at Swansea Bay University Health Board and clinical reader of patient safety and quality improvement in the Division of Population Medicine at the School of Medicine, Cardiff University. And today I will be your host for a panel discussion exploring the link between health literacy, well-being and healthcare outcomes. Now, there are many definitions of what's meant by health literacy. One definition by Sorensen goes, health literacy is linked to literacy and entails people's knowledge, motivations and competencies to access, understand, appraise and apply health information in order to make judgments and take decisions in everyday life concerning healthcare, disease prevention and health promotion to maintain or improve quality of life during the life course. And the premise of today's discussion will centre around health literacy having a fundamental role for building the confidence of patients and service users to confidently self-care and self-manage their disease or condition and interact with the health and care service in a positive and effective way to optimise health outcomes, as well as contribute to the design of sustainable care pathways. Please do feel free to send in questions to the panel via the Q&A tab, and I'll do my best to pose those to our panelists at an appropriate time during the session. Let me introduce you to our panelists this morning. We have Dr. Margaret McCartney. Margaret's a GP in Glasgow, honorary senior lecturer at the University of St Andrews, and is a freelance writer and broadcaster. Margaret is a vocal and respected advocate of evidence-based medicine and is an honorary senior associate at the Centre for Evidence-Based Medicine at the University of Oxford and has serviced as the Royal College of General Practitioners Evidence and Values Fellow between 2018 and 2020. Mrs. Anna T is the Strategic Partnership Manager for Macmillan in Wales, where she's worked for nearly 5 years following a broad career in the NHS that focused on supporting a better patient experience. Now, Anna is known to many in NHS Wales from her leadership and strong advocacy of utilising patient stories for quality improvement during the 1000 Lives campaign and subsequent programmes. Dr. Pauline Ashfield-Watt is the research manager at Healthwise Wales, an online health survey of the people of Wales and register of research-ready participants. Pauline's undertaken research into the primary prevention of chronic disease across a range of settings and is interested in effectively translating research findings for the public benefit. Pauline is also interested in using digital and arts-based approaches to improving health. And finally, Mr. Nick Yates. Nick is a patient after experiencing debilitating symptoms for 6 months without a diagnosis. Nick was diagnosed with Crohn's in 2016. Nick has endured a complex and difficult journey throughout his interaction with healthcare services, but from adversity sometimes comes incredible learning and leadership, and Nick has been a champion across the UK for improvements in patient education and the patient role in self-care and management of inflammatory bowel disease. Welcome, Margaret, Anna, Pauline and Nick. Nick, if I might start with you. You've now suffered with Crohn's for around 5 years, and when I've heard you speak about your experiences of first receiving the diagnosis, Nick, you talk about feeling ignorant to how you could take on an active role to manage the condition. Could you take us back to that time of diagnosis? What do you mean by feeling ignorant to self-manage or engage in your care?
Good morning. Thank you, Andrew, and good morning, everybody. I was reflecting on this for the talk this morning, and I actually think I went through 4 phases, and they crop up several times on my journey. I certainly started ignorant, very much ignorant of what I was suffering from, of how to handle or to manage it, and also to minimise its effects or treat it in any way. I then moved through to a phase of being aware, and this came primarily through diagnosis, because finally there was a name that was attached to what I was suffering from, and then that progressed through referrals, scans and a journey of treatment. I think then I built onto understanding, because I was then aware of the condition I suffered from, and you look out and you're signposted to other sources of information, help and support, particularly via my IBD nurse and my gastroenterologist, but also via the Crohn's and Colitis UK Society, who's been invaluable in making me and other people I know aware of the condition we suffer from. And volunteer groups and education workshops that the charity runs. And obviously we all go on. I think finally this all builds up through ignorance, awareness, literacy of the condition. I'm fully aware of, much more aware of what I'm suffering from, what affects it, and things that I might be able to do to negate acute situations, particularly stabilising flares, identifying flares when they come, and also becoming aware of other conditions that I suffer from, and I know other people can suffer from, that can relate and interact with the autoimmune disease. And finally, I think the literacy builds on the fact that we can start attempting to manage our own situation and also interacting more effectively with the healthcare professionals. I know we'll come on later to things like the patient education workshops, which were very invaluable to me in helping me to understand my situation and interact more intelligently with healthcare professionals. We built on a pilot programme in St Asaph, mid-North Wales, and this clearly demonstrated to everybody involved that my own situation, demonstrated to me that my own situation and what I'd managed to have as support around me was not the usual situation, and I was very grateful for what I've inherited around me.
Thank you, Nick.
I know could have been different on this journey. I think everybody involved could always have more experience of what the condition is, and this gets over that ignorance phase in all of us, in that it's quite easy to make a simple assessment and diagnose what is in front of them. And sometimes that's a little more complicated, particularly in family situations. I've been in workshops with, young people with families, and these can be very complex environments for people to understand and be aware of. So I'm very grateful to the support I've been given, Andrew.
Nick, I should imagine those early months, it's very interesting that you talk about 4 phases of diagnosis, if you like, but those early months whilst you were waiting for that diagnosis must have been really challenging, distressing even, Nick. Flipping it now, I've also heard you talk about, feeling informed to self manage your condition just there, how you collate and track your own data to predict perhaps when a drug is now working as expected, and how that's prompted discussions with your specialist IBD nurse. Could you just tell us a bit about that and what feeling informed really feels like to have that active role in your care?
Yeah, I think these workshops were so powerful. Certainly my IBD nurse and the gastroenterologist were very good. But listening to other testimonials and affidavits and how they had learnt to manage their condition, it became very important to me to take on my own what I was taking in as nutrition, what medication effects were working, what happened in acute flares and things like that. And also being aware of my personal state. I became very aware from the people's testimonials and my own situation, how important the psychology of the environment is and triggers to situations. Building this journal up over days, weeks, months and now years, it's become a very good indicator to me of when things are starting to change from a passive situation to acute. This was exemplified in the summer when I've been very happily in remission on one particular biologic injection. And for no apparent rational reason, nutrition, situation of myself, etc. In fact, the biologic was working perfectly well, but my quarterly bloods then became weekly bloods, were going completely out of control from white blood cell count It ended up in a flare situation with steroids, unfortunately. But the decision was made, having identified to a new one, and thankfully I've now moved on to that, and I'm now in a remission situation. But again, my own awareness and monitoring gave advanced information to my healthcare practitioners that this needed attention paying to.
That's really a helpful example, Nick, about you using your own data to feel in control, to have those kinds of conversations. But also from what you've talked about, Nick, it's more complex than just receiving a diagnosis and taking a pill. There's a lot more in terms of eating well, staying active, having a support network around you. Margaret, if I could turn to you next. GPs have a key role sharing information to patients, their guardians, carers every day. How does Nick's story resonate to your experience of how knowledge and health literacy benefits quality of life?
Yeah, so thanks, Nick, for your information there. That was really interesting to hear, and I think it is just so difficult for so many people, especially during the pandemic just now, trying to take on the responsibility and organisation of managing a chronic condition with all the stresses on the NHS just now in particular. So from the point of view of my work as a GP, you do get, there are many people who are very keen to have every bit of information they can get, to be fully involved with all the decisions around about their healthcare, who want to make active monitoring, who want to really take charge, I suppose, of what it is that's happening to them, what decisions they have to make, and working out how the best way is to do that. And that's terrific, and I would support people as much as I possibly could. There's also other people who would like to do more and lack the resources to do so. And that's not just the wish or the will to become more involved with their own care, but also to do with the amount of pressures that are perhaps elsewhere in their life. Somebody did a study a few years ago to work out how many hours it would take per week to do everything that the guidelines suggested should be done for managing chronic conditions, and basically it was an extremely part-time, if not a full-time job to try and get everything done. And if you're a carer, if you're a parent, if you're someone who's trying to work as well, even just organising your medication to get delivered regularly in a way that you would like to is actually tremendously complicated, and small errors somewhere else in the system can end up having massive impacts from someone else that's downstream. So sometimes even just dealing with the normal stuff that has to be done in order to do the minimum, as it were, can actually be tremendously challenging. And then there are people who really don't want to be making that many decisions, at least at one particular point in their care, and do want to give the responsibility over to a healthcare professional. And then, of course, the professional has to ensure that that is done in an ethical and responsible manner, because, of course, you shouldn't just be making and telling people what they should do. You should still be making sure people are as involved as they can be in decision making and are giving fully informed consent to whatever it is that you want to proceed to do. So I think there's a kind of paradox as well, in that many of the people that I sometimes think could benefit most from intervention aren't able to do so. And what I really want to emphasise is that that's not people's fault. In general, people are already managing something that is challenging in all sorts of different directions, as well as trying to have a life that's not maybe all about their needs, because they've got responsibilities in other areas of life. So I think whenever we talk about this, it's probably really important to remember that there are huge amounts of things that we could potentially be doing for ourselves, but actually the reality of it might make it much more difficult and challenging to do so.
Thank you, Margaret. Now, a lot of assumptions can sometimes be made in healthcare. It's a complex system that relies on many hands to deliver care to patients, and one healthcare professional can very easily assume another colleague has given all the essential information they think is needed for a patient to effectively self-manage their condition. How do you think we can stop patients and service users like Nick from falling through the cracks in the system that's laden, though, with lots of well-intentioned good people?
Yeah, so it's really interesting because I think if you asked, 100 different patients and 100 different doctors what's essential and what should people know, you're probably going to get quite a large amount of answers. So I think, and that to me, I think would demonstrate just how individual everyone is, and how different types of people want different types of information. And of course, it's patients' views here that's the most important, but doctors also have, our healthcare professionals also have a responsibility to ensure that there's a kind of bare minimum, I suppose, that we're giving to everybody, and it's, I suppose, an individual decision about what else is needed on top of that. One of the real struggles that we have in the NHS, and I certainly have, is time, because when you get into a consultation, there are many people who would like to tell me what it is I should be doing during that time, and unfortunately the patient is only one of those people, which is absurd. But ever since general practice went onto this quality and outcomes framework, now thankfully lifted to a great extent in Scotland and in Wales, we've no longer got that pressure of meeting targets all the time, but certainly there are still a lot of administrative tasks that have to be done during the consultation. For example, I've read that doctors should take a blood pressure in every single consultation, or a medication review should be done in every single consultation, or we should discuss smoking in every single consultation. Now these are just absurd kind of claims to be made on time that is quite precious and pressurised. So it's really important that we decide what to do with that best. And one key thing that I'm a strong advocate for is, as much as is wished for, is continuity of care, where you're seeing the same healthcare professionals time after time. You build up experience and knowledge of each other. So I would get to know what kind of information my patient would like. My patient would get to know what kind of things they can get from me, or how I could do things better for them, or we have a shared understanding of what each other knows about what's happening and what's going on. And if I already know what scans have been booked, that there's been a bereavement at home, that there is a delay to the gastric appointment that was meant to happen 3 months ago, that the specialist nurse is off sick, all those things really help me to use that time to the best advantage of everybody. But of course things go badly wrong. I was talking before we went live, I was talking about my frustrations yesterday at work when it took me literally 17 minutes to log on in the morning, and my system crashed twice, meaning that I just gave up and I said, look, I'm going to have to phone you back, to my patient on the phone, because I was getting really actually quite upset with how late I was now running, how overwhelmed I was trying to sort out tech issues, and just feeling that I was never going to be able to help anybody all morning. So I think that the grim reality is that no matter how well our intentions are, if we don't have good systems that are supporting what we're trying to do around about us, things become much more difficult than they are. People get burned out, upset, and I suppose quite distressed at the end of the day, and we end up being less able to help each other, which is dismaying all round.
Yes, Margaret, we're all trying to do our best, really, aren't we, in a system that is highly variable at times. I suppose a slightly controversial question here. I just feel like when patients like Nick are not achieving the optimum outcomes as a result of not achieving health literacy, do you think we should perhaps be thinking of failures to achieve then healthcare literacy as a risk factor, if you like, of avoidable healthcare associated harm?
Sorry, Margaret, you're on mute.
I'm not sure I've got that working.
Is it working? Hear you, Margaret. Go ahead.
Oh. Sorry, these are my ongoing technical difficulties, including at home, as you will see. Sorry, I have a small dog on my lap and I'm trying to be on mute as much as possible, so you don't have to have any more disturbances than is necessary just now. So yes, but I think that what we have to think of this as a system issue. So for example, if I wanted to get really good information on inflammatory bowel diseases, where would I get that information from that's best suited to the person that's with me just now? I should know about that, and it should be really easy for me to find. So I can tell you, when I'm looking for information about sleep quality for patients and how to help things, I go to a website in Australia because it's got a really good sheet that I know prints out reliably and can be really helpful. Now, why is the GP in Scotland having to go to an Australian website? It's because I know this resource and I know it's quite good. So for example, and there's a couple of conditions where I end up actually referring patients or printing out information from websites which I don't particularly like because they've got sponsorship on them or whatever, and they're not really designed for the purpose the information isn't designed for the purpose for which I would like. So to me, that's a system issue, and I'm going to be doing a bit of research around this in the next couple of years, I hope. But it should be really straightforward for me to say, actually, I know some really good information, and I'm going to get it for you just now. And so we can't really expect people, I suppose, who've just been given a new diagnosis to know everything about something, or to become expert overnight. But instead, we should have really clear, inviting, welcoming pathways down which we can say that here are good sources of reliable and trustworthy information, and we'd like you to have a look at that if you would like to. So I suppose that to me that's a big system issue, and we kind of know where the cracks are already. You know, I can tell you where they are, but I can also tell you that no one in my career as a GP has asked me where I think the cracks in the system are and where they could be helped when it comes down to getting people really good information, sadly.
Yes, indeed, Margaret, and listen, I appreciate your candid reflections there. If I could move to you next, Anna, you and your team at Macmillan work really closely with the NHS and other partners across Wales to not settle for anything other than the best possible information and support for people with cancer. Is having all the information well curated and available in many formats the solution here, or are there other important enablers to achieving health literacy, and what are they?
Oh, thanks, Andy. I think absolutely having the right information at the right time in the right format, as Margaret's just talked about, and as we heard Nick saying earlier, is absolutely the best start that we can have. And I think if we're really going to make a difference in Wales, having that as a baseline is definitely the good place to start. But if we think about information in relation to health literacy, it's not the be all and end all. So health literacy is a lot more than having just access to good information. It's around that difference around being able to have the information and then using or being supported to have that information to enable you to understand what's happening. And I think that's the difference in it, isn't it? And from my view is, yes, having good information is a good start, but it's about what do we do with that, and how do we as a whole system, as Margaret's just said really well, support people to really understand what's happening to them. And that, again, it feels a little bit repetitive, but it is so individual. We're all so different, and our circumstances are different. Our ability to understand what's happening to us and make choices is different. But actually, that's that flexibility that we kind of would love to see around having that care that's really focused on that person, on that individual. And it's interesting, I always think when we take a step back from when we think about our healthcare decisions, is we often make decisions relating to our healthcare, and I am speaking massively generally here, and sort of not to criticise anybody, but we potentially do a lot more research into the options for other decisions in our life than we do for healthcare. And it's kind of, there's such a challenge built into the whole system about where to find, and again, Margaret said from her perspective, how do you find access to good information that you know you can rely on, that you know that if you provide that for people that it's good. But as a patient, how do we even know where to start looking if we're wanting to find information out? And how do we know when we do find it, whether it's good or bad or somewhere in the middle information? And especially as we're often in healthcare scenarios, it's like the first time that we've been in that situation. So we wouldn't necessarily even know what we need to know, because it's that whole phrase, isn't it? You don't know what you know until you know you don't know it. I think I've got that the right way around. And it's that, I think, that bigger sort of focus on that cultural relationship we have with health information and health literacy as humans living in the UK, and how we're generally enabled to be more engaged and be active participants in our care, and moving it from us talking about that language, talking about health literacy, talking about engagement, talking about being actively involved, and actually making it something that in reality is just part of what happens.
Thanks, Anna. The third sector is seemingly a key enabler, catalyst, if you like, for achieving health literacy. How can our current system overcome inequalities then in health literacy?
Yeah, it's a really good point, isn't it? Because I don't think it's that unfair to state that access to good quality information is a little bit hit and miss. There are some really good examples, but access is by no means equitable across conditions. I mean, in Macmillan, one of our ambitions is to make sure that every patient or every person that's had a cancer diagnosis or is affected by cancer has access to the information they need to make the decisions. We don't get it right all the time. You know, we've got information, a massive amount of very good quality assured information, but again, it might not necessarily meet everybody's needs if they're coming to it from a different perspective. And that is so relevant on, or dependent, I suppose, on an individual's personal experience. But actually, we should have that across all health conditions, shouldn't we? We should be able to access that information. And also then broadening it, so it's not just specifically around that clinical condition that might be happening at the time, but actually how does that relate to you in your life, your current circumstances, thinking about things. I know, again, a bit of a sort of way too much used phrase, but how do we look at that person as a whole person and think about things holistically? And I know from when we do a lot of work in this area, we talk about that being always a good place to start is from what's important to the patient. And starting from that, but again, as Margaret said, time is has a massive impact on the ability of the system to respond in that way. When I was like preparing for this session, I was doing a little bit of you know, research with a very little r, I suppose I'd call it, but I found that sort of that research suggests that between 43% and 61% of working age adults routinely do not understand the health information that they're provided. And then if we factor into that with so the access to digital literacy, whether we can understand things, and we know we've seen, especially through the pandemic, how much the system is moving towards digital, but actually how many people are actually missing the opportunity to feel empowered and to sort of improve the control about what's happening to them. I also came across a couple of really powerful examples when I was looking into this that I thought really made sense. I'm just going to like read them because I think they explain it for themselves. So there was a lady who thought her positive cancer diagnosis was a good thing. There was a lady who sprayed her inhaler on her neck because she'd been told to spray it on her throat. There was a group of young women who didn't know where their cervix was, and a gentleman who turned up for his appointment because he didn't know the sign for radiology was the same for the X-ray department. Really, really simple, but so powerful and so impactful changes that we can make, and that's just the tip of the iceberg.
Absolutely, Anna, and incredibly sobering statistics and related examples there. Thank you for sharing those. Pauline, we've now heard from Nick, Margaret and Anna about the problems, the gaps between what healthcare professionals intend for patients and what gets received, as well as some solutions and opportunities for improvement for practice. What's being learned in the field of health services research about the benefit then from patient and public involvement?
Good morning, Andy and everyone. Patient and public involvement and engagement in research is an important and it's a growing feature of the research landscape. And there's much support for an evolving research culture that is inclusive and engages patients and other relevant stakeholders as equals. So this approach normalises an interactive process which values the unique perspective of the patient and establishes their place as an integral part of the research process. And nothing can be more important than your source of funding as a researcher, and research funders are increasingly looking for evidence that researchers have engaged with participants as part of developing the research questions at the funding stage. And at Healthwise Wales, we have a patient or a patient partner who works with us on our executive board and reviews all of our applications, all of which have to show that patient and public involvement has been undertaken as part of the projects that we support. So looking at the research process from its earliest stage, an excellent exemplar of research co-production is the James Lind Alliance Priority Setting Partnerships Framework. And these PSPs, as they're called, involve patients, their carers, clinicians and researchers working together to identify what they call treatment uncertainties about given conditions. And these are relevant and have value to the patient, the carer and the clinician. And the top 10 uncertainties for each condition are then published, and they're used for developing research questions and for prioritising research calls by the funders. So this ensures that the research is both valuable and relevant to improving people's lives. Being involved in this way supports the health literacy of all the participants by facilitating effective communication, and that raises awareness of issues that are relevant to the quality of life as well as treatment outcomes. And it empowers the patients and their carers by facilitating a discussion in a forum where all the players are equal. At the other end of the research process, there's a widening array of non-traditional methods being developed for engaging patients and public with research outcomes, and for co-producing research outputs, things like interactive and arts-based media and events, which extend the reach and the impact of the research findings.
Thank you very much, Pauline. And I know you work at the School of Medicine. We're colleagues, we're in the same division. What's the School of Medicine at Cardiff University doing then to prepare tomorrow's healthcare professionals to understand health literacy? You've already highlighted some important and helpful exemplars from the field of research and best practices there, but where's education taking us, and can we expect tomorrow's doctors and nurses and physios to have this coursing through their veins, being aware of the importance of health literacy?
Well, I certainly hope so. In line with the growing interest that there is in patient-centred care and the processes that support shared decision making, students are introduced at Cardiff to patient and public involvement right from the start of their medical degree. And across the full 5 years, there's a theme that's called Understanding People. And this looks at social science, cultural competency and professionalism. And in their third year, students also have the opportunity to interact directly with a patient, following them from secondary care to primary care, and to understand both the care pathways and how health issues are experienced by real people. There are also intercalated degrees which are available in medical education and in population health, and they involve modules such as the medical humanities and management of long-term conditions, both of which promote an understanding of the variations that there are in people's health literacy and the perspectives of the patient. In terms of our research students, PhD students and early career researchers can undertake training in public engagement activities, and they also can apply for seed corn funding to test innovative public engagement methodologies for reporting their research findings, so that people understand how the research findings relate to them and their lives.
That's really helpful, Pauline. And to inspire then those future generations of professionals, healthcare professionals and researchers of the future, are there any specific examples that you share with them to inspire them that health literacy is important?
Yes, well, poor health literacy aligns with the social patterning of non-communicable diseases. So people with poor health literacy have poorer health outcomes. The good news is that good health literacy is associated with healthier lifestyles, better subjective health status, and better health outcomes. Unfortunately, health literacy is a modifiable risk factor, so the more we interact with it, the better it becomes. So, and among the personal benefits, I think, of good health literacy, as the others have alluded to here, are self-efficacy, confidence and empowerment of the patients. And a recent example of that from a colleague who works with patient digital storytelling, Prue Thimbleby down at Swansea Bay. She's done some work with the Royal College of Physicians on, I'll get it right now, integrated patient storytelling, and that's a methodology that she had used to present the findings of a study to better or to understand the needs of service users in relation to personal health records. And one of the resultant digital stories tells of the use of the NHS app's personal health record by a patient affected by mental health issues. And this app actually allows them to record, track mood, lifestyle behaviours, treatment usage, find out information about their medication and contact their healthcare professional. And the app enabled the specific patient to document all of these things, to print off the information and to share it with the GP and have a really useful conversation and a conversation about changing their medication because of putting on weight, which the patient said they wouldn't otherwise have had the confidence to do. So I think these apps and supports to improve people's health literacy can really have a beneficial effect on their quality of life.
Thank you, Pauline. It feels like we've heard from Margaret the cold, harsh realities of the day-to-day grind of delivering healthcare, and they feel very familiar reflections to me. And then, you know, through Nick's difficult journey have come pearls of wisdom, and similarly, Anna, you've been reflecting on where we can get better within the health service space from the third sector perspective. And then Pauline, we've heard about exemplars from research and engagement practices, for example. I'll just sort of try and calibrate where we're at really with this discussion here, and I hope the member of the audience who shared this on chat doesn't mind me reading it out aloud, but they've just shared the following. We need to tackle the paternalistic approach that we still tend to see. Both of my parents have needed healthcare over recent months. They've received good care, but it hasn't been problem-free. We were told off for reading my dad's notes with him and helping him to understand what had happened to him and his treatment. Letters written between primary and secondary care are not written with the patient in mind in our experience. They struggle to even get copies of letters. We can do much better at involving patients in their care. No decision about me without me. Nick, welcome back. We've heard extensive testimonial here that getting the right information to patients and service users in accessible forms is key to help them to achieve better outcomes. We've also heard about the importance of community and supporting people to get the right kinds of information in a timely manner. Now, in recent years, Nick, a growing industry of apps and tech to help patients track and monitor their health and chronic conditions and access information have come about. So I'm keen to hear, Nick, in your experience, do they help? How does tracking and monitoring your condition help you self-manage, and what, if any, are the shortfalls?
Yeah, I had some direct experience of this. Obviously, leading up to the use of a particular app for Crohn's, I've had instituted my own practical personal process of recording and tracking and identifying trends and situations occurring. And when I was presented via the charity Crohn's and Colitis UK, a private company who had they've got various spin-off apps for different conditions. I thought it was just the panacea that we needed. This was the automation of what I was laboriously doing on a day-to-day basis, and I went into it headlong. I'm really wanted to be an adopter to prove that this technology would take my manual intervention, automate it, and then make it directly linked to the healthcare professionals, such that we would close the loop and getting ahead of acute situations rather than weekly consultations, which many times just tick the box and say fine, any problems. I might want to interact with people before them. I ended up stopping the double accounting method of and it was the automated I stopped, unfortunately, because of the technology, and it has data entry because it has also very support tuition around the app as well, based on people's particular symptoms. Unfortunately, it doesn't link IT-wise with anything else in the health board. So my nurses were ignorant of it, my specialists were ignorant of it, and so was my GP. So the only person who was entering the information and getting the feedback was me, and I had that feedback already. And therefore I thought, well, I've got limited time as well, and the manual tracking system has proven on several occasions of impending acute situations. So I went back to that, and I do a graphical feedback on a monthly basis, and I take a photograph of that on the phone and send that to my IBD nurse, and she passes that to the gastro, and several times that's anticipated the need of flares and steroids. It's sad, but we're not there yet. I can see the potential, but we're not there yet.
But thank you, Nick. There was a technological challenge there in hearing some of that, but I think, to paraphrase, it's the disconnect between your well-intentioned efforts to collect and chart your own data, and then that disconnect with the healthcare professionals being able to access it in real time in order to help you make optimal decisions in a timely way. Anna, Nick painted very vivid cons there for one technological solution, and technological issues aside, and for those listening today that missed the extensive discussions on technological challenges for proms and prems on Tuesday, they'll be available soon for you to catch up on. And what do you think are the main challenges here to optimising health literacy based on what Nick's just reflected on?
Yeah, there's a wonderful irony, isn't there, that we're experiencing technological difficulties with having just the access on this session, and I think that says a lot about you know, we can't just be looking at digital as the solution, because we live in Wales. We have you know, there's challenges in just access for a start off, but for me it's fundamentally around how the system actually supports this to happen. And it doesn't rely, at the moment, what we tend to hear is that it relies on individuals kind of working above their station, as it were, in order to make sure that people have the access that they need to the right information and are supported to understand. But actually we should be working towards, surely, a position where that's just because part of what happens, not just as an added extra or something that we can do if we have some extra time in the day. And it's kind of, when we think about it from our own individual circumstances as well, we're all patients ourselves. Everybody, you know, if we don't do it for anybody else, we could be doing it for ourselves as well at this point in time. And how do we even find it acceptable still in 2021 to be handed a poorly photocopied information leaflet, for example? How's that still a thing? How's that still happening? And the pandemic hasn't helped as well with that. And a lot of the information centres that we support as Macmillan, and then more generally in hospital settings or healthcare settings in the round, the removal of information leaflets, for example, is going to impact on people's understanding of situations, and for the right reasons, maybe, in terms of obviously reducing infection risk. But actually, we've just got to acknowledge that is going to have an impact on people having access to the information they need. But as I said earlier, it's not just about that provision of information. And like I said right at the beginning, if we were assured that everybody was sort of routinely offered and encouraged and supported to access the information they need, we would be in a much better position. This is so much more around enabling that conversation, that understanding, the choices that are available, the impact, the language that's used, as I referred to earlier in those conversations, all elements that really support people to have that better understanding about what is actually happening to them. And then also being able to proactively reach out to those groups of the population that may need additional support in order to understand what's happening, and building in that approach to health literacy, just being as part of how we do things, and actually, like I say, thinking whole system, thinking all people from all backgrounds, and just constantly challenging ourselves to do better. I think that's probably, yeah.
That's really helpful there, Anna. I'm just thinking about a case study that inspired me when I first started to became a student, if you like, of value in health. And I was reading about an organisation in Chicago and called Oak Street Health. And what they've got on staff are college graduates that they call data ninjas. And it's their sole job, so they tell us, that it's to work with data that patients like Nick are providing in as close to real time as possible, and analysing the trends, spotting the dips, the challenges that could be afoot. And by doing that, by having a system, an organised way, if you like, of receiving data in a timely way from patients. And this is for lots of conditions, you know, COPD management, inflammatory bowel disease, I'm sure. They've been able to demonstrate that by taking that timely review of data, they've been able to reduce and minimize avoidable hospital admissions, for example. And it just feels like that's nirvana, you know. But then I'm also caught up here with Margaret's quite chilling reflection. You know, in her time as a GP, no one's ever asked her how the system can be better. How can we improve it? And I find that really, perhaps the big challenge ahead is this culture shift that in going forwards, in that we embrace that patients provide us with data, but we work to design and redesign our systems so that we've got the capacity and capability in our teams to make good use of those data as they come through. Now, Nick, I'm going to ask you to reflect a bit more, if that's okay, about how attending the inflammatory bowel disease specific educational sessions have helped you discover the symptoms monitoring app. You mentioned that, and I know you're also a champion for developing routine patient education sessions for IBD patients to help empower them to live well and their condition. You know, everything Anna talked about there, about it's not just the information, it's about having a support network, and, you know, just hearing from the perspectives of others can really help you improve your own experience. Can you tell us then, Nick, a bit more about how these sessions have helped you?
Yeah, can you hear me okay, Andrew? I had to drop out at one point. Okay, thank you. I was diagnosed in Northeast Wales under the Wrexham mailer, and I was signposted to the Crohn's and Colitis as a third sector representative agent for my condition. I didn't find any support around Northeast Wales, and when I moved to Northwest Wales in Llandudno, this increased in lack of support. So I would drive at 7 o'clock in the morning on a Sunday morning to a workshop in East Manchester that was run by Greater Manchester with the Crohn's and Colitis Society. They only had 3 programs running in at Greater Manchester, London, and one was starting in Bristol. That was due to lack of resources, etc., and also getting the involvement of local groups and healthcare professionals. These programs were superb. I went through the whole program of workshops twice over. They were, I just cannot describe how emotional the whole experience is. You have a breakfast meeting room in a motel in East Manchester with over 100 people, and these people have driven from Cumbria, from the northeast of England, from Merseyside, as well as Greater Manchester. We have a wealth of healthcare professionals from all Greater Manchester hospitals, leading healthcare people in pharmacy for autoimmune diseases, for surgery, for paediatrics, for all sorts of nutrition, dietitians, for healthcare professionals that I couldn't access through where I was because of priorities of other things for other people's conditions. But the most powerful thing were testimonials, right from families of 2-3-year-old kids to people who've had this all the way through their working life into retirement, people who've had 3/4 of their guts removed with stoma bags, people who have undergone, and you sit there and think, have I got a problem? Now, if I'd had those frequently asked questions answered when I was in that ignorant phase, or that awareness or understanding phase, I would have been so better able to interact with my healthcare professionals, to ask the questions, to say, what's the impact of this biologic? How long will it last? Why am I getting these allergic reactions to these pills before the biologics and then the infusion wearing off? That gave rise to a passion when I went to Northeast Wales of saying there's nothing like this in Wales. So for people like me and those hundreds of people who've driven to Greater Manchester, they've got nothing. So we got some peppercorn money and we set one pilot workshop before lockdown in St Asaph, which is central North Wales of the Betsy Cadwallader Health Board area. And we had a GP from Bethesda, we had a gastro from Glenclwyd, and we had 2 IBD nurses, We were in the middle of December, just before the March lockdown, cold, wet, horrible evening, and we had 60+ people who'd driven everywhere to get to that event. And there were so many tears of people listening to testimonials who had been diagnosed 2 years before and had yet to see someone as a consultant. It was just incredible what people had been going through and the effort that they made to drive there. So for literacy, that was a powerful statement to me that I am so impassioned now that for my condition and for patients like me, I want to have something like this across Wales, because that charity, the officers said, we now know our role. Our role for people who have this condition is to be an honest broker between the patients and the health sector. Because if we don't, who else is going to be?
Thanks, Nick. A very powerful testimonial there about community and how it enables so much. But Pauline, if I could come to you next now. You've heard about the enablers of health literacy from other panelists, and you know, undoubtedly though, we are in the era of digital developments, wearables, and we have heard about some kinks in using those in routine care, and I've reflected a little bit also. What other digital developments, Pauline, do you think we really need and are going to be key to support us going forwards?
Yeah, so as we heard already, there's a growing number of apps to support various aspects of health, and I think we'll see more and more of those becoming available. And in the medical arena, of course, we've got a number of wearable devices available which facilitate real-time data collection and symptom tracking and facilitate diagnosis, for example, blood pressure monitors and the like. And I think we'll see refinements and extension of the functionality of those sorts of devices, which would further support greater availability of them and faster diagnosis and treatment. And all of these kinds of innovations have been enabled by rapid advances in mobile technology, what's known these days as mHealth. And the market for wearable personal devices, which includes things like Fitbits and the like, is absolutely booming, and predicted that within the next year or so will be worth $90 billion, so global worth. So these devices are creating, I think, and facilitating interest in personal health, and many will be likely to support health literacy and health behaviours. But there are obviously some caveats with that. You know, the quality of them is going to vary, their effectiveness also, and many of them won't actually be able to realise the claims that they make for improving health. So we need to be careful to direct people or assign people to the right ones. Also with the infodemic, or sort of as with the infodemic, there's potential for people with poor health literacy to be overwhelmed and to be left behind and not be able to make the use of these that other people can. So I think that reinforces again the need to signpost patients and the public to digital health applications that have appropriate form, function and usability, and which deliver the desired health benefits for the user at a level of interaction that they're comfortable with. And so where the person prefers less interaction and perhaps has fewer digital skills, offerings such as online digital health stories, and it really makes my heart sing to hear what Nick said earlier. They're so beneficial, these patient testimonials, for giving information about other people's experience with conditions, with the treatment and the support systems that there are around them. And these are likely to be really helpful, not only for the patient, but also for the healthcare practitioner. So moving on then, you know, despite the fact that many of us have contracted Zoom-itis or Teams-itis during the pandemic, I think digital communication technology has and can support remote consultations, interactions and interventions for people who have mobility issues, whether they're caused through lockdowns or otherwise. Notwithstanding, there are many challenges, but I think those challenges will provide opportunities for really good innovations to maximise effective use. And finally, you know, again, as Nick mentioned, online courses using a range of different platforms, methods and media, you know, video written media, interactive ability will continue to make continuing personal and professional development in health literacy an option for a wide range of learners.
Thanks a lot, Pauline. I think the takeaway there for me was leave nobody behind. But finally, Anna, how do we move forward then in a way that supports what matters to patients when the care system is so complex?
Yeah, absolutely. And I think, we in the third sector, for example, are a key stakeholder in this area. And like I said earlier, we acknowledge that none of us actually get it right all of the time. But maybe one of the biggest challenges is the fact that the whole system doesn't necessarily join up and focus on that bigger picture, because ultimately we're all working in this field for the same reason. We might be coming to it from different starting points, but we're actually all after the same outcome, which is a better patient experience, a better health outcome. And meeting people's health literacy needs within all of that is actually such a meaningful and essential part of delivering good care. It improves safety, it improves effectiveness, it helps address health inequalities, all of those different things that we all talk about. And to make that difference, I think we just need to work more collaboratively. This isn't, in my opinion, about the NHS working to improve this with the help of other people. It's about us all taking a step back and doing this together with patients and focusing on what's important, and generating that whole system approach. And going back to the question that you read out earlier, this is about people. This is about you, about me, about people that are listening on this call, and about creating that better system that holds health literacy and understanding of actually what is happening to us as human beings at the front and centre of what we do. I suppose one of the questions that I've still got to sort of finish on is it always remains is who leads this, who actually drives this forward, who makes this happen. Because we have got that opportunity, if we join forces in this space, I think we really could make this transformational and make a huge difference for people across Wales and actually lead the way in that way. But we need to sort of work out, I suppose, who leads it, who drives it, how do we actually make this happen and turn it from a conversation into a reality. Thank
you, Anna. An inspirational note to end on there that we all very much agree on, I'm sure. A huge thanks to our panellists this morning, Mr. Nick Yates, Dr. Margaret McCartney, Ms. Anna T and Dr. Pauline Ashfield-Watt for such honest and thoughtful and action-provoking reflections to us all. To wrap up this session, can I please ask each of our panellists to give us one very short key takeaway message in the order of Nick, followed by Anna, Pauline, and then Margaret. Over to you, Nick.
Thanks very much, Andrew, and thanks everybody for attending the session. I come back to the beginning with Margaret, and several times for me, my journey through this condition has been significantly changed by the GP, and it's the GP considering the whole patient situation, and that comes down to time constraints, Margaret, doesn't it?
Thanks, Nick.
Okay. From me then, I think it's just remembering this is about people. This is and doing our best by people.
I've got a quote for you, not my words, but I've plagiarized this a bit. Assessing a patient's health literacy serves as the first step in changing the clinician's behaviour.
And Margaret.
I'm going to be really cheeky and put in 3 things because I lost the technology for a while. This is my dog. So my big thing, first of all, is about evidence. Everything we should do should be evidence-based, and that's really important when it comes down to technology. It's really tempting to think that technology is going to be universally useful. I think some of it is, and I think some of it won't be, and some of it has a tremendous opportunity cost. And you may find that patients spend a long time analysing, taking in, responding to calls for data, and they're not that useful for them at the end of the day, and actually they congest precious time in a consultation. So it's just be really careful about what we use for evidence, but certainly there's lots of potential for benefit, and of course there's also potential for conflicts of interest to creep into this space, so we just need to watch out for that as well. And the other thing I want to say is that I am so pleased to have had the support of Sally Lewis and Sarah Pantone in NHS Wales to help develop a course which is intended for everyone, called Our Health, Our Knowledge, and we'll hopefully be able to launch it in the next month or two. And it's designed to be a generic course for people who are interested in making more decisions for themselves in healthcare and want a bit of background, because we know that the consultation is so pressurised for time that we wanted a resource to use and reflect on and have to call upon out with that. There'll be basic data and basic information and more detailed information within it, and we will publicise it very widely. You will not be able to get away from our calls to have a look at it and analyse it. And it's been written by a patient group and some GPs, and we really hope it will be useful. And 100% kudos and thanks to Sally Lewis and for Sarah for taking on the work to get it finished. Thank you so much.
Thank you, panelists, and thank you everybody for joining today's session. Have a great afternoon.